Hi, welcome back to the question answer series. I'm Dr. Asha Baxi and my today's question is to Dr. Damodar Rao from Coimbatore. Dr. Damodar Rao is the laparoscopic surgeon and infertility specialist from Rao Hospital, Coimbatore. He has received several awards in the field of hysteroscopy and laparoscopy, and he has been invited as an operating surgeon in many workshops all across the India. My today's question is going to be on torsion of the ovary. You all would agree that this is one clinical condition which is often misdiagnosed, and it has its implications in the future fertility, especially of the young girls. So Damodar, give us the tips how to diagnose and manage torsion ovarian cyst and what is its gravity if left neglected.
Hello everybody, I'm Dr. Damodar Rao, Associate Director, Consultant in Fertility and Laparoscopy at Rao Hospital, Coimbatore. My topic for today is ovarian torsion. So what is ovarian torsion? Ovarian torsion is basically twisting of the structures around the ovary, resulting in intense pain, and this is seen in the reproductive age group mostly, and it's seen in about 20% of pregnancies too. It causes intense pain. Patient will report to the emergency department with nausea, vomiting, intractable pain, very severe, and sometimes rarely even with fever, which can further confuse the diagnosis. Who is at risk for developing ovarian torsion? So any woman with an ovarian cyst, it could be a simple ovarian cyst, or those who have long-standing cysts, actually like polycystic ovarian syndrome or a dermoid cyst. And these cysts usually should be somewhere in the range of about 4 to 5 centimeters, they say is ideal, which helps it, rotate. And the slow rotation of the cyst around the axis results in torsion of the ovary. People who had also IVF treatment to develop, multiple cysts are also at risk. Pregnant women are also at a high risk, about 20% chance of developing ovarian torsion in pregnancy. Coming to diagnosis, yes, definitely based on the clinical signs and symptoms that I've mentioned. Transvaginal ultrasound is the mainstream of diagnosis. Basically, you will see an ovarian cyst of 4 centimeters in size. You might see some fluid in the pouch of Douglas. The follicles may be pushed to the periphery. Due to the twisted ovarian pedicle, you'll see something called the whirlpool sign. And on Doppler, you might see a reduced flow or no flow many times too. Coming to treatment, you'll have to give her a painkiller immediately, a strong painkiller, and then arrange for surgery as soon as possible. Laparoscopy is the mainstay of treatment. I immediately put in a scope, and then we always look at how the ovary looks. Many times it might appear quite dark because of necrosis and hemorrhage. Detort the ovary and wait for a couple of minutes. Many times it will change color. Even if it changes color mildly, salvage the ovary, do not do an oophorectomy. This ovary will survive. Once this is done, do a cystectomy or at least aspirate the fluid, whatever is convenient for you, and always plicate the ligament. Plicate the ovarian ligament. This will prevent recurrence. I always prefer to do the hot dog in the bun technique. Prognosis, most of these women do well, especially if you've plicated the ovarian ligament. During surgery, always look at the opposite ovary too. In case there's a long ovarian pedicle, you can prophylactically plicate the other ovary too. And some of them you can even put them on OCPs to prevent a recurrence. And because she's had a torsion and the ovaries being detorted, it does not affect her fertility, and she's able to conceive spontaneously and carry on to term pregnancies. Thank you.